A seemingly ordinary night in the emergency room transforms into a moment no healthcare professional would ever forget. When a Marine falls from his wheelchair in the emergency corridor, everyone around rushes to help him up. But only one nurse notices something no one else saw. What she discovered in that moment completely changed the course of that night and revealed a disturbing truth that had been hidden in plain sight. This is a true story about professional intuition, about those silent signs that only experience can capture, and about how a second of attention can mean the difference between life and death. My name is Laura Brennan, and I have been working as an emergency room nurse for 12 years. 12 years of sleepless nights, critical decisions made in seconds, and moments that test everything you think you know about medicine and human nature. I grew up in a small town in Ohio, where everyone knew everyone, and life moved at a predictable pace, but I always knew I was meant for something different, something that would challenge me every single day. That is why I moved to San Diego, right after nursing school. The pace here is relentless, the cases are diverse, and every shift brings something I have never seen before. That particular night started like any other Thursday evening shift at Mercy General Hospital. The emergency room was moderately busy, nothing we could not handle. We had the usual mix of patients: a construction worker with a possible fracture, an elderly woman with chest pains, a teenager who had a skateboarding accident, and several others waiting for assessment. The fluorescent lights hummed overhead, casting that familiar harsh glow that makes everyone look slightly more tired than they actually are. The smell of disinfectant mixed with coffee from the nurses' station filled the air. My colleagues, 2 other nurses and 3 residents, moved through the corridors with practiced efficiency. I had just finished checking vitals on a patient in room 4 when I heard the commotion near the entrance. The automatic doors slid open, and 2 paramedics wheeled in a man in his early 30s. Even from a distance, I could tell he was military. There is something about the posture, the way they carry themselves, even when injured. His jaw was set in that determined way that spoke of discipline and training. He wore civilian clothes, jeans, and a gray t-shirt, but his bearing gave him away immediately. If this story has already grabbed you, go ahead and subscribe to the channel now, because what comes next will surprise you even more. The paramedics briefed Dr. Stevens quickly. The patient's name was Marcus Reynolds, a 29-year-old Marine who had served 2 tours overseas. He had come home 6 months ago and was adjusting to civilian life. According to the report, Marcus had been experiencing severe lower back pain for the past 3 days. That morning, the pain had intensified to the point where he could barely walk. His wife had called 911 when she found him collapsed on their bathroom floor, unable to move his legs without excruciating pain. The paramedics had transported him in a wheelchair because any movement caused him visible distress. His medical history showed previous injuries from his service, including a herniated disc that had been treated conservatively with physical therapy. Dr. Stevens nodded, scanning the chart quickly. He was a competent physician, someone I had worked with for 5 years. His initial assessment was straightforward: acute lower back pain, possibly a worsening of the previous disc herniation, maybe even nerve compression. He ordered pain medication and scheduled Marcus for an MRI as soon as the imaging department could fit him in. Marcus was wheeled to a curtained area in the emergency room to wait. His face was pale, covered with a thin sheen of sweat that indicated he was in significant pain, despite trying to maintain his composure. I introduced myself and took his vital signs. Blood pressure slightly elevated, heart rate a bit fast, both consistent with someone experiencing severe pain. His responses to my questions were brief but polite. Yes, the pain was in his lower back. No, he had not injured himself recently. Yes, it felt similar to his previous disc problems, but much worse. No, he had not noticed any other symptoms. Thank you for staying with me this far. This shows you feel the same way I felt when I lived through all of this. So go ahead and subscribe and turn on the notification bell, because what comes now changes everything. About 40 minutes after Marcus arrived, I was charting notes at the nurse's station when I heard a loud thud, followed by gasps and hurried footsteps. I looked up immediately and saw several people gathering near the corridor where Marcus had been waiting. My heart rate kicked up instantly, that familiar surge of adrenaline that comes with every emergency. I dropped my pen and rushed toward the scene. Marcus was on the floor, his wheelchair tipped slightly to the side. 3 people were already there, including Dr. Stevens and one of the residents, Dr. Patel. An orderly and a visitor who had been walking by were also kneeling beside him. Everyone was focused on helping Marcus sit up, asking him if he was hurt from the fall, checking for any new injuries. The concern on their faces was genuine. A fall from a wheelchair can cause serious complications, especially for someone already dealing with back problems. Dr. Stevens was asking Marcus if he had hit his head, if anything felt broken, if the pain in his back had worsened. Marcus was shaking his head, saying he was fine, that he had just lost his balance trying to adjust his position in the wheelchair. His voice was strained, embarrassed even. You could see he felt terrible about causing a scene, about needing help. That military pride, that reluctance to appear weak, it was written all over his face. But while everyone else was focused on the fall itself, on getting Marcus back into his wheelchair safely, I noticed something that made my blood run cold. It was not about the fall. It was about what I saw in the split second before everyone surrounded him. Marcus had been trying to shift his weight in the wheelchair, and when he moved, I saw his left foot. More specifically, I saw that his left foot was turned at an unnatural angle, rotated outward in a way that should have caused him to react, to wince, to do something, but he had not reacted at all. Now I want to hear from you. Where are you watching this story from? Write it in the comments. It is incredible to see people from so many places following stories like this. And if you are enjoying this, hit that subscribe button, because the next parts are going to reveal things you will not believe. The image of that foot stayed burned in my mind as everyone helped Marcus back into his wheelchair. The angle was wrong, completely wrong, and he had not even flinched. As an emergency room nurse, you develop an instinct for these things. You see thousands of injuries, thousands of pain responses, and you learn to read the subtle signs that something is not right. What I had just witnessed contradicted everything about a typical back injury. I stepped closer as the group dispersed, everyone satisfied that Marcus had not sustained any new injuries from the fall. Dr. Stevens patted him on the shoulder reassuringly and told him the MRI would be ready soon, that we would get to the bottom of his back pain. But I could not shake what I had seen. I crouched down next to the wheelchair, pretending to check that the brakes were properly engaged, and I took a closer look at Marcus's legs. His jeans covered most of his lower legs, but I could see his feet clearly. Both feet were in sneakers, but the position was unmistakable. The left foot was still rotated outward, sitting at nearly 90 degrees from where it should be. I reached out carefully and touched his left ankle, watching his face closely. Nothing. No reaction whatsoever. Then I did something that made my stomach drop. I pressed my pen lightly against the top of his left foot, gradually increasing the pressure. Marcus continued talking to Dr. Stevens about his back pain, completely unaware of what I was doing. That was when I knew. This was not just back pain. This was not a herniated disc causing sciatica or nerve compression in the way we had assumed. Something else was happening, something far more serious. The complete lack of sensation in his left foot, combined with that abnormal position, pointed to a neurological emergency that we were missing while focused on the obvious symptoms. But how could I convince the team to look deeper when everyone, including an experienced physician, had already made their assessment? I stood up slowly, my mind racing through possibilities. Complete loss of sensation, foot drop, acute onset. The combination was alarming. I looked at Marcus again, really looked at him, the pallor of his skin, the sweat, the way he held himself rigid in the wheelchair. We had attributed all of that to pain, but what if it was not just pain? What if his body was compensating for something we had not identified yet? I needed to act, but I also knew I had to be careful. Nurses questioning a doctor's assessment can be tricky, especially in a busy emergency room where time is critical and decisions need to be made quickly. Dr. Stevens was a good doctor, someone who respected the nursing staff, but I also knew he was under pressure. We had multiple critical patients that night, and Marcus had seemed straightforward based on his history and presenting symptoms. I walked over to where Dr. Stevens was reviewing another patient's chart. My heart was pounding, that familiar anxiety that comes when you know you are about to challenge a decision, when you know you might be wrong, but the stakes are too high not to speak up. I took a breath and kept my voice calm and professional. I told him I had noticed something concerning during the fall. I explained about the foot position, about the complete lack of response to touch, about the foot drop that suggested something more than a simple disc herniation. Dr. Stevens looked up from the chart, his expression shifting from distracted to attentive. He asked me to show him. We walked back to Marcus together, and I demonstrated what I had observed. This time, Dr. Stevens performed the neurological checks himself. He tested sensation in both legs, checked reflexes, assessed motor function. His expression grew more serious with each test. The left leg showed significantly reduced sensation compared to the right. The reflexes were abnormal. And when he asked Marcus to flex his left foot upward, Marcus could not do it. He could not lift his left foot at all. Dr. Stevens straightened up, and I saw the shift in his demeanor. The relaxed confidence of treating a routine back pain case had vanished, replaced by the focused intensity of a physician recognizing a potential emergency. He called Dr. Patel over and asked him to examine Marcus as well. Then he turned to me and said we needed to expedite that MRI immediately, but we also needed to add contrast and and expand the imaging to include the entire spine and potentially the brain. I felt a wave of relief mixed with growing dread. Relief that my concerns were being taken seriously. Dread about what we might find. Dr. Stevens ordered immediate blood work, including markers for infection and inflammation. He also asked me to start a second IV line and prepare for the possibility that we might need to administer high-dose steroids or other emergency medications, depending on what the imaging revealed. The next 30 minutes felt like hours. I stayed close to Marcus, monitoring him continuously. I rechecked his neurological status every 10 minutes, documenting any changes. The lack of sensation in his left leg seemed to be spreading. When I tested his right foot now, the responses were also becoming diminished. This was progressing, and it was progressing fast. I informed Dr. Stevens immediately, and the urgency in the department shifted. Marcus was no longer just another back pain case waiting for a routine MRI. He was now a priority. When the imaging department called to say they were ready, we moved quickly. I accompanied Marcus to radiology, staying with him throughout the scan. He knew something had changed, that the medical team was now treating his condition with much more urgency. He asked me what was wrong, what I thought was happening. I chose my words carefully, explaining that we were ruling out some serious possibilities, that the loss of sensation in his leg was concerning enough that we needed to look very thoroughly at what might be causing it. Tiranan, sir, the radiologist called Dr. Stevens before we even got Marcus back to the emergency department. I could see it in Dr. Stevens' face when we rolled Marcus through the doors. He met us immediately, his expression grim. He asked me to bring Marcus into a private examination room rather than back to the curtained area. That alone told me the news was bad, very bad. Once Marcus was settled, Dr. Stevens sat down and spoke to him directly. The MRI had revealed something unexpected and extremely serious. There was a large abscess, a pocket of infection, in the epidural space of his spine. The abscess was compressing his spinal cord at the lumbar level, which explained the progressive neurological symptoms. But it was not just localized. The infection had spread, creating multiple smaller abscesses along his spine. Some of the vertebrae showed signs of osteomyelitis, a bone infection. This was not a simple back injury. This was a spinal infection that was destroying tissue and cutting off nerve signals to his legs. Marcus stared at Dr. Stevens in disbelief. How was that possible? He had not had any procedures, no surgeries, nothing that would introduce an infection into his spine. Dr. Stevens explained that spinal abscesses can sometimes occur spontaneously, often from bacteria traveling through the bloodstream from another infection site in the body. Had Marcus been sick recently? Any dental work? Any cuts or wounds that might have gotten infected? Marcus thought for a moment, and then remembered. About 3 weeks ago, he had developed a painful boil on his shoulder. He had drained it himself at home, cleaned it with hydrogen peroxide, and it had seemed to heal fine. It had not seemed like a big deal, but that small infection had been a very big deal. The bacteria, likely Staphylococcus, had entered his bloodstream and seeded into his spine. For weeks it had been growing silently, forming abscesses that gradually compressed his spinal cord. The back pain he had been experiencing was his body's first warning sign, but by the time the neurological symptoms appeared, the situation had already become critical. If we had not caught it that night, if I had not noticed that foot during his fall, Marcus could have been permanently paralyzed within hours. The emergency department exploded into controlled chaos. Dr. Stevens immediately contacted neurosurgery and infectious disease. Marcus needed emergency surgery to drain the abscesses and decompress his spinal cord. Every minute counted now. The longer the spinal cord remained compressed, the higher the risk of permanent nerve damage. We started him on massive doses of intravenous antibiotics, broad-spectrum coverage to fight the infection while we waited for culture results to identify the exact bacteria. I stayed with Marcus as we prepared him for surgery. His wife arrived, her face pale with fear when we explained what was happening. She kept saying she should have made him go to the doctor sooner, that she knew something was wrong, but he kept insisting it was just his old back injury flaring up. I held her hand and told her that spinal infections are notoriously difficult to diagnose early because the symptoms mimic so many other conditions. No one could have predicted this. The neurosurgeon, Dr. Kawamoto, arrived within 20 minutes. She reviewed the imaging quickly and confirmed what we already knew. This was a surgical emergency. She explained to Marcus and his wife that she would be performing a laminectomy to access the abscess, drain the infection, and relieve the pressure on the spinal cord. There were risks, significant risks. The surgery itself was complicated, and the infection had already caused damage. She could not guarantee that Marcus would regain full function in his legs, even with successful surgery. But without surgery, paralysis was certain. Marcus looked at his wife, and in that moment I saw the full weight of what he was facing. This was a man who had survived combat, who had faced enemy fire, who had carried wounded brothers on his back, and now he was facing the possibility of never walking again because of a bacterial infection from a boil he had barely thought about. His wife squeezed his hand and told him she loved him, that they would face whatever came together. Marcus nodded at Dr. Kawamoto. He was ready. This was were. The surgery lasted 5 hours. I finished my shift at 7 in the morning, but I could not leave without knowing the outcome. I waited in the staff lounge, drinking coffee that had gone cold hours ago, checking my phone repeatedly for updates. Finally, Dr. Kawamoto emerged from the operating room. The surgery had gone as well as could be expected. She had drained multiple abscesses, removed infected tissue, and decompressed the spinal cord. The vertebrae showed extensive damage from the osteomyelitis, but she had been able to stabilize the spine. Now it was a waiting game to see how much nerve function Marcus would recover. I visited Marcus in the ICU later that day, even though it was my day off. He was sedated but stable, monitors beeping steadily, IV lines delivering antibiotics and medications. His wife was there, exhausted but holding his hand. She thanked me, tears streaming down her face, for noticing what everyone else had missed. She said the neurosurgeon had told her that if the infection had gone undetected even a few more hours, the damage would have been irreversible. Over the following weeks, I checked in on Marcus's progress. The infectious disease team identified the bacteria as methicillin-resistant Staphylococcus aureus, an aggressive strain that required 6 weeks of IV antibiotics. The recovery was slow and painful. Initially, Marcus had no movement in his legs at all, but gradually, with intensive physical therapy, sensation began to return, first in his right leg, then slowly in his left. 3 months after that night in the emergency room, Marcus took his first steps with a walker. 6 months later, he was walking independently, though with a slight limp and ongoing weakness in his left leg. I saw him one more time, when he came back to the hospital for a follow-up appointment. He made a point of finding me in the emergency department. He shook my hand and told me that Dr. Kawamoto had explained everything to him, how close he had come to permanent paralysis, how the quick identification of the spinal abscess had saved his ability to walk. He looked me in the eyes and said thank you for paying attention, for trusting my instincts when something did not seem right. That case changed something fundamental in how I approach nursing. I had always been thorough, always been attentive, but Marcus's case taught me the critical importance of trusting your gut, even when it goes against the prevailing assessment. Everyone that night had seen a Marine with severe back pain and a history of disc problems. It was the obvious diagnosis, the expected diagnosis, but medicine is not always obvious. I learned that the most dangerous moments in healthcare are not always when we lack knowledge or resources, but when we think we already know the answer. Confirmation bias is powerful. Once a diagnosis seems clear, it becomes easy to interpret all subsequent observations through that lens. The fall from the wheelchair should have been a red flag, but everyone, including an experienced physician, saw it as just another complication of Marcus's back pain. No one except me noticed what his body was actually telling us. This experience reinforced my belief in the value of nursing observation. Nurses spend more time with patients than anyone else in the hospital. We see them at their most vulnerable. We notice the small changes, the subtle signs that something is not right. Our role is not just to follow orders and administer medications. Our role is to be the extra set of eyes, the persistent voice that asks questions when something does not add up, even if it means challenging authority or risking being wrong. Stories like this make us reflect on how many times the signs are right in front of us, but only some have eyes trained to see them. This experience marked me deeply and changed the way I look at every patient who walks through the emergency room doors. Now I want to hear from you. What would you have done in that situation? Would you have trusted your intuition or followed what everyone around you was saying? Leave your opinion in the comments. This is very important to me. And if you have not subscribed to the channel yet, this is the perfect moment to do it. We have many other real nursing stories that will leave you speechless. And do not forget to watch the next recommended video. There is a story that will make you question everything you think you know about what happens in hospital corridors.